Welcome again, everyone. This is Lisa Moicambo, and I'm one of the Senior Program Officers on the Challenge Initiative at the Center for Communication Programs at Johns Hopkins Bloomberg School of Public Health. This is going to be the fourth in our AYSRH Office Hours series. And just for some background, the Challenge Initiative's AYSRH, or Adolescent and Youth Sexual Reproductive Health Shared Vision and Goal, are to envision a world where young people are empowered to live an optimal reproductive life. And specifically, we're working towards rapidly and sustainably scaling up evidence-based approaches to increase use of modern contraceptive methods among all women and girls 15 to 49 years of age in urban poor areas. This includes a special focus on empowering young people by improving their knowledge and attitudes about contraceptives, improving their self-efficacy to use and access contraceptives, and creating an enabling environment to allow them to freely obtain informed choice services. As I mentioned, this is our fourth webinar in this series, and we had kicked off our AYSRH programming with a face-to-face master training of coaches and trainers. And we knew from the literature that one-off trainings aren't sufficient, so we have been planning these webinars to dive deeper into topics that we haven't been able to explore as deeply as we would have liked to. So we'd like to welcome today our speakers and thank them for taking the time out of their busy days from World Health Organization and UNFPA to speak to us about leveraging digital health for youth sexual and reproductive health. So today we have with us Dr. Gerrit Mel, and I apologize for butchering any names, who leads research on digital health innovations at WHO. He leads evidence synthesis and guidelines development through the WHO Technical and Evidence Review Group on mHealth for reproductive, maternal, newborn, and child health, and is co-lead of the Health Data Collaborative Working Group on digital health and interoperability that focuses on supporting country-level investments into standards-based digital health information systems. Then we'll hear from Sylvia Wong, who is the innovation lead for UNFPA. She leads innovation initiatives and manages partnerships to source, implement, and scale up new solutions, including digital health, design thinking approaches, and data innovations for women, girls, and young people's sexual and reproductive health. Previously, Sylvia was UNFPA's technical specialist on adolescents and youth and provided expertise and evidence-based programming support to UNFPA's country offices and partners on adolescent health and development, as well as project advisor on reproductive health. Last but not least, we'll hear from Leanne Gonzalez, sorry about that, who is the technical officer at WHO and PhD candidate at University of Basel. She is WHO's focal person for sexual health and also coordinates the ARMADILLO study, which assesses the effect of mobile phone technology to provide sexual and reproductive health information to young people aged 13 to 24 years old in Kenya and Peru. For a little bit of logistics, we'll give each presenter between 10 and 15 minutes. There might be a little bit more time required. So as a result, please make sure to type in any questions into the chat box. On my screen, it's actually at the top. It depends on, I think, your layout. We'll collect those and we will try to share with the presenters as many as possible at the Q&A at the end. If we're not able to, we'll see if we can get responses to them and send those out via a Word document along with the recording after the webinar in the next few days. So now I'd like to turn over the controls to Dr. Gerrit. Gerrit, do you have them?
Unmute myself. Lisa,
you should have control now of the slides.
Okay. Great. Can you hear us, Lisa?
Yes, very well.
Terrific. Thanks so much, and I'll control from this side. Thanks so much both to the Challenge Initiative and Lisa. It's a real pleasure and an honor to present to the audience. I want to talk a little bit about some work that we have been doing at WHO and also in collaboration with UNFPA, both in the area of digital health and in the area of adolescent health and reproductive health. So I think all of us are intimately aware with different guidelines documents that have been produced that specify different health interventions that are relevant at different levels of the health system. The challenge, of course, Lisa, I'm having trouble controlling the slides. There we go. The challenge is ensuring that these interventions of known efficacy, which are described in the guidelines documents that I've just shared, are ensured that they're accessible to populations of adolescents and others in the population, and that they're delivered with quality as well as they're delivered equitably. In digital health, a lot of work has been done over the last few years around delivering these interventions of known efficacy and using digital to overcome challenges that are in the health system. And those may be things like a poor demand for services or failure to follow guidelines or a commodity stock out. And digital has been used to kind of overcome those barriers and bridge those gaps. Next. And so what I'm going to do in this presentation is talk about two things. One is a recently released guideline document on recommendations on digital health for health system strengthening that we led, which will help you to understand what are the types of digital approaches that are effective for ASRH and more broadly in health systems. And then secondly, I'll discuss and describe an area that we've been doing with UNFPA called Digital Accelerator Kits. And this is health content and data content that could be leveraged for any software system to help to facilitate good content on those systems. And I'll speak specifically about the area of ASRH. Next. If we think about digital health, we think about three different content areas. We think about the health content and whether that's in fact aligned with those recommendations like the handbook or the recommendations around family planning or contraceptives, as well as the indicators that are recommended and data elements that are recommended that help us and countries to understand whether both the system is performing well, but also whether beneficiary populations are benefiting adequately. The second question we have is, if we think about the use of digital, we think about specific functions. We think about things like decision support or targeted messaging or the use of e-learning approaches. And those we call digital health interventions. They're discrete functionality that could be used in any system. And lastly, we think about the digital software, the applications that can take the health content and the digital health interventions and ensure that those are delivered at scale to all the populations that need it. Next slide. In thinking about these three areas, we think about, is the content aligned with clinical and public health guideline recommendations? Number two, we think about, with these interventions, we think about, do these specific capabilities like decision support contribute benefits or harms to health sector? And three, do these software systems, are they able to deliver at scale and for the use cases like adolescent health? Next slide. The work that we've been doing over the last several years focuses on ensuring that we get the right health content translated from a clinical or public health guideline or the data, recommended data and indicators into something that we call a digital accelerator kit, and that's the health content. The second is recommendations around digital health interventions that are derived from evidence review. And those are the guidelines themselves that I'll speak about briefly at the beginning of the presentation. And then the last and third thing is really software that is able to scale nationally and interoperate with other systems. Next slide. The first area I'll look at and talk to you about is this guideline. And the guideline answers the question, does the ICT capability, like decision support, contribute benefits or harms to the health sector needs, and is it recommended? Next slide. When we started to develop the guideline, we put together a group of people who helped us to identify 85 different functionalities in the use of digital health for health system strengthening at 4 different layers: at the client level or the patient level, at the health provider level, at the system manager level, and as services like laboratory systems and things like that. And so we took 9 of those interventions and we did evidence systematic reviews to determine which of those should be recommended for use by a government or by an implementing partner. Next. And that would relate to any different health program area. And so the digital guidelines that were released in April provide a basis for making decisions around different functionality that could live in any system in order to strengthen health system across not just ASRH, but any health area. And there are 10 recommendations that reflect 9 different intervention types. Next slide. And you'll see things like birth notification, stock notification, client to provider telemedicine. These are all areas that are interventions, digital health interventions that are described in the guideline. And you can see on the right the kind of common scenarios of usage across the health system at different levels of the health system and across different use cases, including adolescent health. Next slide. We looked at those interventions and we looked to see to what extent they would be helpful for facilitating gaps in the performance of a health system at different layers of accountability, supply, demand, quality, and affordability. And it was our intention to ensure that we were able to identify digital uses at these different layers and make recommendations around those. And some of you may be familiar with the Tanahashi framework, which is a helpful framing for where these different pieces can fit together. Next slide. I'm going to focus on 2 of these areas and talk specifically about the health content and how to make sure that those who are deploying digital health record systems or tracking systems like electronic medical record systems combined with decision support systems. How can we ensure that the content is appropriate for adolescent sexual and reproductive health and that it reflects the clinical and public health guidelines? Next slide. While my colleague Leanne and also Sylvia will be presenting on the client side applications. In this slide, I indicate the specific recommendation that was made around digital tracking and decision support systems. And you can see here that WHO recommends its use on the basis of the evidence base, but that we also note that it can be challenging to implement. And so it's important to make these considerations and ensure that the decision support is in line with what the health workers should be already doing within their operational guidelines of their specific health cadre workforce, but also that the implementation considerations around training and other things are taken into account. Next slide. When we think about these systems and the decision support and tracking, what we're trying to do is we're trying to make sure that we're translating these clinical and public health recommendations into these systems. And to be honest, in their use in paper or even in digital, it's been fairly challenging to ensure that those recommendations are put into practice. Next slide. So oftentimes these recommendations related to adolescent health or the broader umbrella of reproductive health are available, but they're not often used to the extent that we'd like them to be. It's also challenging for countries to incorporate those clinical recommendations into digital systems. There's a fair bit of subjective assessment about those. And so health workers themselves are often put in a position of collecting data for reporting, but not necessarily for their own uses on improving service delivery and quality. Next slide. And then when a ministry actually is looking at different digital systems, there is a wide variety of systems that are out there, and it's quite difficult for them to be able to understand what the content is and whether that's aligned with what WHO or UNFPA or others would recommend in terms of the decision support logic, but also in terms of the data content. And so being able to move from their paper systems to digital tracking and decision support systems requires not only those systems are adequate and are going to be able to go to scale, but also that they're confident in the content that would live on those systems as well. Over to the next slide. And so I'm going to talk a little bit about digital accelerator kits. So you've just heard about the 10 recommendations that came out of the guidelines, and I'm going to focus on 2 of those. And ensuring that the content for 2 of those recommendations, being decision support logic and client tracking, that the content is aligned with clinical and public health recommendations aligned with SRH. Next slide. So a digital accelerator kit is work that we've been doing with UNFPA, WHO, and the part of WHO that we work in HRP. And we have 3 different accelerator kits that are going to be released later this year. One is on family planning, another is on sexually transmitted infections, and the last is on antenatal care. You can see each of these include adolescents. So we decided not to develop a specific ASRH digital accelerator kit, but rather embed in adolescent content within each of the accelerator kits so that it becomes a seamless experience when they're using a digital system, that they can switch between adult or an adolescent and they don't have to go to a different app, but rather they would be providing care and they would be able to switch over in the event that it's an adolescent in front of them. A digital accelerator kit serves as an operational complement to the WHO clinical and public health guideline recommendations, but also the data recommendations. And it helps to facilitate a much easier transition into these digital systems. Next slide. Digital accelerator kits fit into this spectrum on the far left in the health content area. And you can see the types of systems that would be able to absorb and include the content from a digital accelerator kit are software systems that you may be familiar with and may have already used yourself: DHIS2, ComCare, OpenSRP, Medic Mobile, and many others like that, even electronic medical record systems. Next slide. Those are systems that are widely used in countries, and so the digital accelerator kits provide an opportunity for facilitating a country's ability to adopt that content into those systems. The accelerator kits provide a systematic documentation of minimum data and health content based on recommendations from guidelines that are evidence-based, including decision support logic. They provide a starting point. It's not the entire thing that a country would have, but it's the 80% of what will make it easy for a country to make slight adaptations and incorporate it into their country's systems. It's also independent of the software itself, so that in the event that a country is using ComCare at national scale or OpenMRS at national scale, it's not tied to a specific product. It's standards-based and allows a country to absorb that regardless of what system they're using. It also allows those software implementers and partners to ensure that when they're asked by the government around whether the content that they have in their systems is aligned with WHO, they can say yes. Next. A digital accelerator kit includes 6 or 7 different areas, including who is the intended user of a software product. Is it a nurse or is it a community health worker? Is it a skilled worker, a non-skilled worker, or is it both? User stories, so the common descriptions of narratives around how someone might be engaging with the health system and the user of the software system itself. And then the business processes and data workflows. So in the event of coming into a facility, what happens next? And are decisions needed? And are laboratory tests required? And the specific processes that are important. The fourth area is data elements. So ensuring that not only are the data captured for indicator population, but they're also captured for decision support logic so that service provision quality can be improved. Likewise, decision support logic is described and is easy for those systems to incorporate alongside specific ICT standards to make it interoperable with other systems. And then additionally, that indicators and the ability to monitor the performance of the system, but also the health of the population is also embedded in these systems. Next slide. The scenarios of use for an accelerator kit. I have a digital system, but I want to ensure that the data and decision support content aligns with norms and standards. Scenario 2, I have a paper system, but I want to transition to a digital system. I want to make sure that I optimize it, I streamline it, I make it better, and that it's also aligned with what is recommended. Scenario 3, I want to implement WHO guidelines in a digital system, but I don't know where to start. And that might be from a vendor or it might be from a Ministry of Health perspective. And lastly, I want to ensure that my digital system uses standards, including things like the ICD, International Classification of Diseases, and HL7, which is a standard for data exchange. Next slide. We use the Pareto principle, which is we're certainly not going to be able to provide all the content and variability in how these systems will be used, but we will provide an 80% of what we expect a country to need, and the 20% will be the adaptation that they will need to go through themselves. And that makes it a lot easier for them to be able to do that adaptation at country level. Next slide. In order to get to an accelerator kit, it's critical to look at the different guidelines, the data recommendations, handbooks, and any other asset that exists that is evidence-based, and bring these together in an accelerator kit into those 6 or 7 different areas that I spoke of. Next slide. And this is just an example of the many different things that you'll find in there that reflect workflows, in this case, between a nurse midwife and their clients. Next slide. And in this case, I'm highlighting the specific elements that relate to adolescents and the incorporation of head score assessment within a counseling business process. Again, it's something for the software vendors and the ministries to check against and determine how different it is, and then go through that process of adapting it into their existing systems. Next slide. Next slide. Thank you. And so this is work that we've been doing with UNFPA and also with Ministries of Health, and mainstreaming this approach to a number of different processes that they will be using in order to assess their systems, in order to digitize and optimize the way that they use digital for ASRH, as well as the entire SRM and CAH care continuum is the intent here. And we are going through that process of helping countries to understand these tools, and then work with software vendors and investors to make sure that these systems are fit for purpose, aligned with recommendations. And we expect that there'll be a lot more accelerator kits coming along the way. And we're very excited to be working across UN agencies on this area. Thank you.
Thank you, Garrett. Sorry about the controls issue. It looks like I should have set up my computer differently from the beginning. So my apologies. Thank you for your patience. And I'd like to invite Sylvia if you don't mind, to the presentation, and I will be advancing your slides. Can you hear us, Sylvia?
Yes, great. Thanks, Lisa. Can you hear
Perfect.
me?
Yes, we can.
Okay,
Thank you.
wonderful. Well, thank you, Lisa. Thank you, colleagues, for joining this webinar. And as what Garrett said, it's very much a privilege and an honor to participate and to share about the experiences of UNFPA, the United Nations Population Fund. We're the Sexual and Reproductive Health Agency, and we work to ensure that there's zero maternal deaths, zero unmet need for family planning, and zero violence against women and girls. And obviously, whether young people thrive, are supported from their transition from childhood to adulthood, makes a huge difference of where of how we support them and the futures that they and the promises they have for the world. And so I'm very pleased to be able to share about what we're doing on demand side digital approaches for adolescents and youth, so that they could decide whether, when, and how many, and with whom, for the children, and for the children that they would wish to have in the future, but more importantly, so that they can have positive sexual and reproductive health lives. So this is a complement to what Garrett had shared. This is our starting point. As I had spoke before, UNFPA had supported a range of adolescent and youth programs around the world. In 2017, however, we want to take stock of some of the different efforts and investments across geographies, particularly on digital for young people. We want to review what were our investments across the organization, and we wanted to have to get those learnings, or just a quick snapshot of how that could help steer a vision for what we need to do for the future. Because as you can see from this map, and this is just a snapshot of what we were able to capture about UNFPA supported projects. At the time, there were about 32 that were mapped, primarily concentrated in East and Southern Africa, but certainly there are many other efforts that have started since then, or even at the time when we mapped these different efforts, were not adequately captured. So, so this is just to share with you that this was to steer where our future investments would be, what we want to do, what we want to learn from the different efforts underway. Many of the projects focused on increasing young people's knowledge and skills around sexual and reproductive health. Lisa, next slide, please. Thank you. The majority of what we mapped did aim to increase sexual and reproductive health knowledge among young people. There were also some that were linked to services, but not all. Some of the groups were also targeted at, or some of the projects were also targeted at specific subgroups, whether it is adolescent girls, specific out of school young people, or even pregnant girls for that matter. But by and large, the majority aim to increase sexual and reproductive health knowledge, including HIV. When we were looking at the different innovation principles, whether it's designing with the user, are we data driven, are we taking scale from the start, having that mindset, we found that across the board in this internal mapping, that design with the user was the main innovation principle that was applied across these projects. And certainly we had a long way to go, because we also found that many of these existing solutions were not built on open source platforms, and hence there were some vendor lock-in with trying to access the content or some of the code. So this was a big major lesson learned for us going forward. We also found that there was a huge need to reuse and refine existing models and technologies. And because we're a global organization, we're across the world in 140 countries, it's not often as easy as much as we wish it to be able to share across these geographies, so that we could reuse, refine, build on each other's approaches. And that's a huge aim of what we want to do moving forward. Likewise, across the projects, we found that there was a need for stronger monitoring and evaluation frameworks and approaches so that we could support the knowledge of what we were gathering, the app effectiveness, so that we would have a stronger proof of concept and be able to have the evidence and wherewithal to say, this is where we want to go and this is how we could scale and expand to reach more young people. So in summary, we found there was a need for more sharing, consolidating what we've learned and what we're seeing to embed more strongly with the programmatic landscape so that we can leverage and build on other efforts and to avoid duplication as well. Lisa, next slide, please. So where this has steered us is what we're calling a global mHealth for and with young people. Their starter pack. It's a digital starter pack, and the aim is to drawing from what we've learned from this snapshot is to provide a foundation where we would be able to facilitate and deploy high quality, cost efficient, reusable and scalable mHealth solutions with and for young people. And the objectives of which that UNFPA is building out with many partners um, around the world and also especially with our country offices and their partners is to provide the programmatic resources for these mHealth solutions in order for offices and partners to be able to plan, implement, deploy, and maintain, eventually scale and evaluate the solutions they're building out with and for young people. Where there's a software component where we'd be providing reusable or open source software that could be locally customized, building on what Garrett had said about the 80-20 principle, where we will build out what is generalizable for all young people, regardless of geography, age, because there are commonalities across young people wherever they will live. At the same time, we reserve the 20 to 30% that needs to be and should be locally customizable. So for the specificities of specific target groups to be reached, language, local customs, etc. And we're not doing this alone. We've established an internal community for knowledge and resource sharing across the UNFPA organization, who then reaches out to and with the young people to do the youth-defined research to be able to crowdsource and to share what's working, what young people want, where they want it, and how. And here I'd like to give a shout out to some colleagues who may or may not be on the line, who's been spearheading this initiative with at UNFPA, and these colleagues are my colleagues Gilles, Nayanesh, Eric, and others who are working directly with our offices around the world and their partners. Lisa, next slide, please. So here, as I said, this is what the 80% could look like. These were main functionalities that we heard from our teams around the world, and most importantly, the young people with whom design thinking research has been conducted. And they include 4 main parts. One is on the on-demand sexual and reproductive health information access about what do they want to know, what are some critical content that is important to young people to be able to navigate and manage their sexual and reproductive health. Secondly, we heard from the young people and from our teams that they want a peer-to-peer communication, but also chat with a knowledgeable person, whether that's a counselor, whether that's a nurse, etc. So that on demand, they would be able to have access to questions, questions that they may not feel comfortable asking face-to-face, but still important for them to know. We heard as well that young people want to know, well, if after I know what I have these questions, where can I go? Where can services be assured or quality can be provided? And here we are going to be building in a sexual and reproductive health service locator. And finally, personal health management. When to have nudges, to be reminded for clinics. We heard from a lot of young women, they would like to see a menstrual tracker so they would be able to understand how their body works, when their period will come, etc. So these are the 4 four main functionalities that we're hearing from young people that we're building out. And again, we've heard that young people want multimedia. They they would also wish for offline capabilities and different channels for delivery, whether that's on SMS or text to speech, etc. And throughout this, we want to ensure that the content is quality assured and they have the interactive features that they would wish to have. Next slide, please. Thank you. Here you can see some screenshot iterations that we're working on. And what I was saying earlier on the right, on the left-hand side, we've categorized it about what is it, my knowledge, my services, my health, and my voice, so that young people will be actively engaging with one another and sharing their insights of what they're learning. My knowledge, there you could see much of it follows the international guidelines for sexuality education that's issued by the UN or UNESCO, and it's following very much with to ensure body literacy, literacy in sexual reproductive health, and life skills, life goals, and planning. So again, it's about how they want it delivered, on what content, etc. And it's flexible enough to be able to allow for new functionalities to come to bear. We're exploring different ways of incorporating frontier technologies, whether it's AI, predictive analyses, or text to speech, or looking at the possibilities of incorporating natural language processing. So for non-English or non-UN specific audiences, of course, native languages to be able to allow better reach for young people who may not be as literate, but wish to use a voice function in order to access information and services for which they want to use. Okay, so next slide, please. Here's my last slide. So in addition to young people telling us what they're interested in, what they want to know, how they want it to be delivered, we wanted to also ensure, like, well, how do we know it's working? How do we know this app is performing and doing what it should be doing? So to accompany this mHealth Starter Pack, UNFPA is also building out a Learning for Impact toolkit to exactly determine some key questions and key answers around the topics that we talked about. First is on the systems and analytics. Basically, is the app doing what it should be doing? Performance metrics. Is it crashing? Is it slow to load content? Is it doing what we want it to do? So then, by taking stock of or asking some specific questions, we can make the required action, for example, update the software or to do some other tinkering with the software. We also want to know, well, who's using this app? Are they coming often? Are they active? Are they staying on the digital solution long? Are they or are they just visiting for 10 seconds and then disappearing? Well, by gathering these types of metrics, then we would be able to, again, determine what do we need to do. For example, if you need to really increase or to ramp up a marketing campaign and look for specific subgroups of adolescents to reach, that could be another action based on what we could be tracking in the usage. In addition, engagement, are they coming back, as I was saying earlier? Well, do they like the experience? Do we need to improve the user interface? So ways to ensure sustainable active engagement. While downloads and active engagement is good, we ultimately want to know, well, is it doing what it should be doing? The business analytics side. Health output metrics such as, are users learning from the app? Are they coming back for more? And here we can assess, well, what questions are popular? What questions do we need to do a deeper dive in order for the learning to happen? And finally, is there a link to behavior change by by accessing this information, by actively engaging, is it motivating the young people for health-seeking behaviors? And here, this is more of the long haul aim, but certainly we wish to follow this, to be able to see, well, if it's leading to the behavior change we want to see, then that's a success for us all. We'll see a return on our investment across the geographies and to reach more young people around the world. So with that, let me end here. And thank you very much for everyone for joining.
Thank you, Sylvia. We appreciate it. We have received a few questions and I'm definitely noting those down. I'm not sure if we'll have time to get into those right now, but I'll make sure to follow up with the relevant presenters and circulate responses after the webinar. I'd now like to invite Leanne to come speak.
Hi, I'm here.
Great, thanks, Leanne. I will let you take over.
Great. Thank you, everyone. Again, it's a pleasure to join you this afternoon. So Garrett and Sylvia have both been talking from a very sort of looking across ministries, looking across implementation of SRH digital health interventions happening around the world, really looking to set standards. I'm going to narrow the focus focus on one study. Garrett's in my department, the Human Reproduction Program, has a research mandate. And so with that research mandate, next slide, please, Lisa. I'm not sure I do have control. Thank you. So with our research mandate, we initiated in 2014 the ARMADILLO Study, which is a mouthful of an acronym that stands for the Adolescent, Youth, Reproductive, Mobile Access and Delivery Initiative for Love and Life Outcomes. And we initiated this from a realization that we were seeing, and it's part of this sort of enthusiasm that we saw for digital health across the space around the same time, but particularly when it came to SRH, people would say, okay, well, young people will have phones, young people are hard to reach on SRH, so digital for SRH is a match made in heaven, but we didn't see the evidence backing that up. So that was where the ARMADILLO study came in, and we worked with collaborators in two countries, Kenya, the International Center for Reproductive Health, and I believe we have colleagues who are listening to this webinar from there, and Peru, the Universidad Peruana Cayetano Heredia, who's based out of Lima. We had two objectives. The first stage was to develop SMS content that was tailored for and vetted by youth. And we were really focusing on the focus of this intervention being on demand, so menu based, using numbers to drive the menu, on demand and free. And then stage two, after developing this content in each site, to be able to rigorously evaluate the effect of this content using the gold standard in research, randomized controlled trial. Next slide, please. This is just to show you the results very quickly from both sites. I will be focusing on the results coming out of Kenya for this presentation, but just to say that in Peru, where our RCT was focused on young people ages 13 to 17, we found that the way that they preferred to have this menu-driven system was to have questions, a very informal, who am I, who can take care of me, how can I have fun? They came up with 7 sexual and reproductive health domains with 25 subdomains, which you can see there, and a total of about 100 SMSs across all of these areas. Next slide, please. Meanwhile, in Kenya, what we saw here, we were dealing with young people ages 18 to 24. They were much more focused on thematic areas. So you can see they had domains rather on everything from puberty and anatomy to STIs, HIV, pregnancy prevention, reproductive health and rights. And here we had something like 80 subdomains, and each of these had between 1 and 3 SMSs associated with them. Next slide, please. All of the content that was from stage 1 was developed. The domains were identified with young people in collaboration with national and regional adults working in sexual and reproductive health, and then all messages were vetted by young people in the formative phase. Okay, so stage 2, we'll start to narrow down on the Kenya results. Stage 2 took place in Kwale County. part of the coastal region of Kenya. Next slide, please. And it was a 3-armed randomized control trial. So in one arm, we had our intervention, which, as I mentioned before, was a numbers-based on-demand system, very similar to those of you who are familiar with the mobile money system M-Pesa in Kenya. It was designed to be modeled very similarly to that, but via SMS. We had a control arm, which is to say imitating standard care with access to no intervention. And then I would say most interesting for the digital health world was that we introduced this, what we called the contact arm. And this was meant to help us understand whether what we were seeing, if we saw an effect, if it would be due to the digital interaction, so being poked by a digital system to say, go think about your sexual and reproductive health, or if it was the content itself. So our hypothesis was that we would see a greater effect for those receiving both the poke from the system and the content, so the armadillo intervention, and then we would for control, and that our contact arm, maybe being prompted to go learn about SRH on your own, what we saw in the contact arm, might also see a bit more improvement over our control arm. The study period lasted for 7 weeks, and then there was an end-line survey, and then there was 8 weeks of nothing, and we did a follow-up survey after that. Next slide, please. So our primary objective was to evaluate the effect of Armadillo to dispel myths and misconceptions about contraception in particular. I'll note that we specifically chose not to power the study around behavioral outcomes because there are, I mean, this is no surprise to anyone on this call, but there are obviously, when you look at the framework, I guess, moving from a young person having information to being able to act on that information and actually access services and see some behavior change. There are quite a lot of steps in between, and what we've seen in some of the limited literature that exists is that having just digital health, getting access to this information alone, is not necessarily going to result in a change in behavior, and the study would have had to be huge to power. Our sample size would have had to be massive to attempt to determine any change there. So we opted to look at seeing whether we could use access to this information to get rid of some of those nagging myths and misconceptions that often stop young people and adults from taking on contraception. Secondary outcomes, of course, we did look for other changes in sexual and reproductive health knowledge, attitudes, and behaviors. And then we were also interested in evaluating the retention of that outcome. So that's where that period between end line and follow-up, those 8 weeks, becomes important. Next slide, please. So in developing a primary outcome measure, we did a review of the literature, but also did focus group discussions with young people to identify what the common myths and misconceptions are around contraception. Many of these transcend different regions, but you know, it's everything from contraceptives can cause cancer, they reduce a woman's libido, they can result in deformed babies, can make it harder to get pregnant. And we identified 10 salient myths among Kenyan young people. Next slide, please. And what we did was we developed a simple index. So we took the 10 common myths and misconceptions and created an index of those 10 myths at baseline and end line and follow-up, young people were asked to tell us whether they strongly agreed, disagreed, or strongly disagreed with that. What we ended up doing is dichotomizing the results of that Likert scale. And so if someone agreed with the myths, that is, they believed the myth, they received a point. If they rejected the myth, they received no points. So what we would expect to see, as at the bottom right here, we would expect to see that at baseline, people would have a higher score out of 10. They would believe more myths than they would at end line, that we would see a decrease when it comes to our primary outcome from baseline to end line. Next slide. So our results, and I have that these are preliminary because we are finalizing, we're so close to finalizing our primary outcome paper right now. So you are seeing these before they are published, and so they may be tweaked slightly before they come out. Next slide. Just to say here, I won't dwell on this, but our baseline characteristics, we had about half of our young people age 18 to 24 had been to secondary school. Yes, had been to secondary school. Most of them were single. Most of them did not have children, and slightly more than half of them were male. Next slide. And all this is a lot of graphs, but all you need to see here, if you look at myths, the people who use contraceptives end up with health problems. The idea that hormonal contraceptives are fattening and contraceptives can harm a woman's womb. Those were our three most salient myths at baseline. So you can see that across the three arms, you're looking at about 2/3 of young people believing those myths. And what you see is that from baseline to end line, we see a drop, which should be exciting until you realize that you're seeing this drop across all three arms. Next slide, please. So what we saw is in our intervention group, where we would expect to see a decrease because these guys have access to the armadillo content. Oh, what happened? Lost it. There we go. We saw a decrease of 37.5% in terms of average number of myths believed from baseline to end line. Very exciting. Next slide, please. However, when you factor in the control group, the group that had no access to the intervention, you see that there's almost a 30% decrease in the number of myths believed from baseline to end line. That's a bit concerning now. And the last one, and when you lay the contact group, again, the people who were just nudged and told, go think about your sexual and reproductive health, go think about pregnancy prevention, etc. What we saw is, again, a very similar decrease, almost 37% from baseline to end line. Next slide. And what I want to emphasize is that there is a significant difference noted between baseline and end line for each of the arms individually. However, when you look at that decrease, as you can see the decreasing line going down, what we found is that the difference between those arms is not significant. So we have no way of saying, based on these results, that the armadillo intervention was significantly better than no intervention at all. Next slide. Now, there's a little bit of extra information that you need here before we start to interpret what this means, and that is when you factor in the follow-up. So here's something slightly different. This is for, I believe, puberty knowledge. So we wanted to look, you remember that our secondary objectives were to look at broader SRH knowledge and then the ability to retain that knowledge. So we had a scale for puberty, sorry, this isn't labeled, where a maximum score, if someone had the correct knowledge related to puberty, they would score out of 6. So here you can see, similar to the primary outcome, that we see all three arms improving significantly their amount of knowledge from baseline to end line. However, what's interesting is that this increase kind of tapers off, as you would expect to see following the end of the intervention. Once again, significant improvements in all three arms, but there's no significant difference between the arms. Next slide. So what does this mean? So as I mentioned before, there's no significant difference between the arms. We cannot say that the armadillo intervention was better than a contact nudge or no intervention at all. However, what we did see was that there was significant improvement in arms from baseline to end line in each arms. And we also know that the improvement ends with the intervention period. So once the armadillo intervention left the study area, that improvement that we saw across three arms also tapered off. Now, something that might explain this is that there was quite a bit of contamination between arms. For those of you familiar with research, we individually randomized our participants, which means that in the study area, we might have had young people who could have been living across the street from each other or living next door to each other who would be in different arms. And when we asked our contact and our intervention arm participants, between like 23 and 27% of them told us that, yeah, I got these messages and I shared them, which is brilliant if you're running a service, less good if you're running a research study. And we can also say that our study partners have checked very closely, and we can say that there was no other campaigns going on in the area. Next slide. So takeaways, what does this mean? So all of this being said, we have reason to believe that there is probably some effect if you make this information available. I will say we need differently designed studies. I would highly suggest that people do a cluster randomized controlled trial if they want to do an RCT. And for people who are in this space, we all know that doing RCTs on communication campaigns and digital communication in particular is extremely difficult. I will say, and I think that the guidelines and the literature's reviews that Garrett and colleagues did as part of the digital guidelines development process echoes this, that digital interventions alone are likely not going to be sufficient to affect change on AYSRH related outcomes. That being said, I don't want to say that there's no point in doing this, because what we and many others in the literature have found is that these kinds of interventions are highly acceptable. With the advent of WhatsApp and other data-based messaging applications, they're becoming increasingly cheaper to do. It's a wonderful way of reaching young people, and that they are worth exploring as part of multi-pronged interventions. But, be wary of the person that tells you that digital interventions and access to information alone is going to be enough to make you see changes in behavior, changes in, health, impact, etc. That's probably not going to be the case. I think that might be, oh, nope, sorry. Yeah, so just a quick for next steps for analysis. We have shared this with our colleagues in Kenya, ministries in the Ministry of Health and at regional levels. We do hope to be finalizing our primary results paper and submitting it in this coming month, and we will be drafting the secondary results paper by the that's meant to say the end of 2019. For those who are interested in how Peru went, just to note that Peru looked at on-demand, which was the armadillo intervention, versus push. And they are actually seeing, I think their preliminary results show that push was showing the people receiving push messages did see some significant improvements in their outcomes. Next slide. And then for the content itself, we want to make sure that this is available for future adaptation by implementers. So what we are doing right now, working with partners, is to try to track down lessons learned and best practices from about 10 years worth of AYSRH plus digital programs to make sure that it can accompany this content. And last slide. With the goal of kind of incorporating into the accelerator kits that Garrett mentioned before, just a document that both has the armadillo content for anyone who would like to adapt it, but also being able to highlight some specific considerations for developing and implementing digital health programs. This is something we're working on, not just with WHO, but with other agencies. We've collaborated, we've reached out to UNFPA and UNICEF with this, and the goal would be to scope existing digital health related resources from the UN agencies and other partners, to coordinate with experts working in this space, and to reach out to a small group of people who've been working in this to get some input. So I would say please keep a lookout for that in spring 2020, and I will stop there.
Thank you so much, our three presenters. I'd like to specifically echo a number of the chats mentioned how they were really fascinating to hear the armadillo results, and they appreciated the candid sharing, especially given that some of the results were unexpected and that there were no significant difference in outcomes between arms. No, yeah, I would like to see this. Okay, so, and Sylvia, thank you for jumping in and responding to a number of the questions that were posed specifically to UNFPA in your part of the presentation. I guess one question would be some of the resources mentioned in terms of the kits and the guidelines. Do those all exist in French? And as the presenters, would you be okay if we had your slides translated into French for our colleagues here joining us from Francophone West Africa?
Absolutely.
Yeah, absolutely. And the guidelines are in French as well.
Awesome. Wonderful. We really have very little time left, and I know everyone has busy schedules, so I'll make sure to follow up with the other questions that have come in, and we can see if we can get answers back to everybody along with the recording. So once again, thank you so much to the speakers this morning and afternoon your time. And we will be in touch soon.
Great, thank you.
Thank you.
Thank you, everyone.